thank the Sitaram Jaipuriya Foundation for giving me this opportunity and inviting me today, including the organizing committee. It's great to see so many friends here from the world of diabetes and cardiovascular medicine. First of all, I must say I'm doing injustice here on two fronts. First of all, there are many eminent speakers here who could talk about diabetes in the Asian continent more than I can. And secondly, I think 20 minutes again doesn't do justice, and you really need a whole day or a weekend to talk about diabetes diaspora among the Indian continent. What I'm going to try and do is talk about diabetes in India, but also compare it to what we have in the UK. In terms of the Sitaram, just regarding my background, I'm of Indian origin. I've only lived in India 2 years when I was very young. I'm from Porbandar. And where I'm from, the elderly, when they meet, the first thing they say to greet you is Sitaram. So Sitaram to you all today. So the next few minutes, I'm going to take you through epidemiology and comparing UK and India, risk factors for type 2 diabetes, inequalities in management, and potential solutions. In terms of the epidemiology, this is the diabetes in numbers. This is the diabetes atlas, which is published every year or every 2 years. This is the latest one, showing global number of people with diabetes. As you can see, in India, there's nearly 90 million people with diabetes. This was estimates for 2024. But the estimates are by 2050, there will be 156 million people with diabetes. Now, the problem is this is an underestimate. If you look at the top, this is people aged 20 to 79 years, and I'll show you why this is an underestimate, because diabetes occurs much, much earlier in the young population in the Indian subcontinent. These are data from Dr. V. Mohan at the front here. These are probably some of the best data there are from India in looking at the prevalence of diabetes for the ICMR India Diab study. And as you can see, the prevalence of diabetes starts increasing from a very young age. We get people from the age of 20 and below having diabetes. But as you can see, it escalates. When we used to talk about diabetes, no one had diabetes, type 2 diabetes I'm talking about, before the age of 40, 50 years ago. Now we're seeing more and more what we call young type 2 diabetes. These are also very recent data looking at the rising burden of diabetes in India. Incidence is rising from 1990 to 2021. The prevalence is rising. The mortality is rising. But it looks some good news here. There is some stagnation of mortality over the recent years, and DALI is increasing as well. This is again from the ICMR India Diab. We've been talking about BMI quite a lot. And again, we can see that the prevalence of diabetes increases with BMI. But in the Indian subcontinent, people get diabetes at a much, much lower BMI, as you can see, increasing at BMIs of around 20. UK, we've done similar studies. When we compare it to the whites, South Asians have more diabetes, 2.5 times more diabetes. Impaired glucose regulation, pre-diabetes 40% more, high risk of cardiovascular disease, and high risk of all these conditions. So even when Indians are migrated to countries outside of India, we carry this higher risk. This is again from our study in the UK of a large cohort of patients. Even Indians in the UK have a high proportion who are under the age of 40, what we call young type 2 diabetes. South Asians, you can see the proportion of South Asians who are under the age of 40 is about 25%, compared to the white European, which is around 5%. So what are the risk factors for type 2 diabetes? But there are some simplistic views of key factors in the development of diabetes, underlying undernutrition, reduced pancreatic function, and then increasing adiposity, which we've been talking about, rapid urbanization, then the behavior changes, as well as some environmental exposures that lead to diabetes with the genetic predisposition in certain populations. However, it's more complex than that. I don't think we have really worked out the exact reasons for the increase in diabetes among the Indians. And we've thought about this quite a lot, and we think it's a lot of it's about genetics, but also the body fat percentage, which I'll talk about and carry on with the theme. Lifestyle, diet, conventional risk factors. There were novel factors, genetic factors, epigenetic, interuterine factors, the thin fat phenotype which has been mentioned, migration, deprivation, and environment, I think, is playing a key role as well. So this is data from the UK showing that diabetes occurs at a younger age and at a lower BMI among South Asians compared to whites. So we looked at hundreds of thousands of patients here. As you can see, South Asians develop diabetes 12 years earlier than white populations. South Asians also get diabetes at a lower BMI. So 12 years earlier, lower BMI, and when we diagnose them, their diabetes is less well controlled. Their HbA1c, the control for glucose, is much, much higher. And the other problem in the UK for the Indians is that South Asians live in more deprived area compared to the white Europeans. We've talked about BMI cut points, excellent discussion here. So this is a study we did with Anup Mishra, looking at the Indian cohort from Jaipur, UK cohort from Leicester, that's Indians from UK, and whites. So it's a great way to look at risk factors when you have a multi-ethnic population that we live in Leicester. Leicester has 50% of Leicester population is Indians, mainly Gujaratis. What we see here is the glycemic factor, the time which puts people at risk of diabetes. And we call obesity a BMI of 30, which we talked about for white Europeans. Well, Indians get that at a BMI of 22.6. So majority of you are obese, I'm sorry. We gave this evidence to the NICE for guidelines, and they wouldn't accept 23 as a cut point. They said that's too low. Basically, you would not be able to motivate anyone. Everyone has a BMI of 23. And so they went for a BMI of 25 instead, because they thought it was impossible to try and motivate people if they said to everyone that your BMI needs to be below 23. So health interventions really are required, as we've talked about, at a lower BMI for South Asians. What are the other reasons for this increased risk? So we did a lot of work in COVID because we were the first ones to show that Indians were affected more than the white populations when COVID hit us. Previously, it was mainly in homogeneous populations such as China, Spain, etc. We started getting calls saying, Kamlesh, more Indians are going into intensive care unit at a younger age. Have you looked at this at all? So we started looking at this, and then suddenly we found that clearly Indians were more at risk of COVID, more at risk of getting COVID, more risk of deaths as well. And so we did a lot of work during COVID. And so the increased risk in COVID in ethnic minority risk, we said it's because of poor control measures, language barriers, vaccine hesitancy, poor uptake of screening, increased exposure to the virus because they have roles in key worker roles where they're exposed to the virus more, dense housing, increased vulnerability to disease, increased stress, etc., with psychological problems, and then worse social environment, poor working conditions, poverty, etc. Well, we say you could easily take that COVID out and put cardiometabolic diseases, and the same risk factors would hold for development of cardiovascular diseases and cardiometabolic diseases, poor control measures, increased exposure to risk factors, increased vulnerability, and worse environment. Just going through some of the other novel areas are, and again, we can do this in the UK because we have a white population, a South Asian population. So our research group have an interest in physical activity and lifestyle intervention. So we looked at what proportion of people are complying to guidelines for physical activity. So looking at moderate to vigorous physical activity, using objective measures, using actigraphs, so it's not questionnaires, which we know are not reliable. So when we looked at this, South Asians have less moderate to vigorous physical activity compared to white populations. Sleep is becoming a major risk factor for cardiometabolic diseases, diabetes and cardiovascular diseases. And variability in sleep timing, not getting good quality sleep, is again, seems to be worse in South Asian populations, both men and women, compared to the white populations. Then there's a range of attitudes that are different, we find, in South Asians in the UK. And I think true, that holds here for the Indians in India as well. About illness belief, poor knowledge about lifestyle. So we talk about in the UK, so we need culturally adapted self-management interventions. So when we speak to a white person and screen them that they've got diabetes and things, there's a sense of real physical illness they get, sense of bereavement they get. Well, when we talk to the South Asians, we say, you've got diabetes. These are qualitative studies we've done. And they always have some excuses why they've got this and why they can't do interventions that may help them lose weight or reduce their risk. And some of these are true beliefs. Because of different cultures, we worry about our children and our future. This is more so in the UK than India, but I think this holds in India as well. In the past, we used to live together, share our worries, but now you're on your own. And then when we say you've got diabetes, I said a white person is really shocked. They get this bereavement, oh my God, I've got diabetes. When we tell an Indian person they've got diabetes, they say, well, my dad was diabetic, but he had passed away now. My mum was diabetic, so I knew all along the line I would end up with diabetes. Or blame it on someone else, blame it on God. It's all to do with God, whether you get diabetes or not. Now, these are really, really difficult cultural norms that we have difficulty changing. If you've got an attitude like this, there's no matter what you do, you have to try really hard to change these attitudes, to try and reduce the risk of developing diabetes in this population. What about inequalities in management? This is, again, from Anjana and Mohan's team. Looking at risk factor control. Diabetes is quite simple. If we manage it well, simple things, do simple things well for people with diabetes, their risk of mortality is the same as someone who doesn't have diabetes. That's been shown before from Sweden. But however, despite having good therapies, we see only about a third of people have their glucose controlled. About half the people have their blood pressure controlled. About 2/3 have their lipids controlled. So huge proportion of people are not getting control of these simple risk factors. When we compare it to globally, this is the largest population-based study, prospective study we did with 15,000 patients across the globe. What we see is when therapies are started, second-line therapies, third-line, we're too late. We're leaving people in high glucose, high risk factor control for much, much longer. So as you can see in India, people's HbA1c was 8.6% before the next line of therapy came. We really need to be intervening much, much earlier. Access, we've talked about fantastic therapies, access to CRP, access to biomarkers, access to MRIs, liver scans. But there are a large proportion of people in India who don't have access to simple medications. This is the large PURE study done by Salim Yusuf, and a number of people here were involved in that study. So metformin is the commonest drug. That's available for the majority of people. But many of the other drugs are not available, as you can see on the right-hand side in India. So no matter how much we talk about these expensive tests, when you haven't got the basics there, it's going to be difficult to manage these populations. UK has a universal health coverage. No matter who's there, we will get free healthcare for everyone. And despite that, we have inequalities in care. So this is data from London. We've shown similar data that people of Indian origin, ethnic groups, blacks, are less likely to get intensification with second-line therapy or insulin therapy compared to the whites, despite having universal free access to everything. Now, why is that? So these are kind of questions that we're asking why this is. And there are many reasons. We've talked about GLP-1, this fantastic therapy that you lose weight, you improve cardiovascular risk. There are other similar drugs called SGLT2 inhibitors, transformational drugs, organ protective drugs, and now very, very cheap. And this, we looked in the UK population, and what we see is people of ethnic minority, South Asians, are less likely to get these drugs than whites. Despite South Asians getting these diseases at an earlier age, they're less likely to get these organ protective therapies in a universal health coverage system. So finally, just on to solutions. We have done a huge amount of work over the last 30 years trying to increase awareness among populations, patients, healthcare professionals. One of the main risk scores that's developed that has been recommended by NICE, our guidelines, is the Leicester risk score, which we developed with our patient groups in large studies. And this is a simple questionnaire patients fill in themselves, and then they go to the healthcare professional to have their blood glucose checked. We've converted that into different languages, 4 or 5 different Asian languages as well. I mentioned about simple things that can be done. These are simple, cheap drugs that bring glucose down. And this is a study set off from our group looked at, and it's showing, just getting the glucose down with these simple drugs, you reduce your risk of heart attacks, of microvascular kidney outcomes, feet outcomes, neuropathy, retinopathy, eye outcomes, particularly retinopathy, and kidney outcomes as well. The other key thing, and Dr. Mohan, our group, looked at this with an international group to say, really, we need to start these therapies from day one. As soon as someone is diagnosed, you need to start them, bring the HbA1c down. And the reason is they have legacy benefits. So if we start early, they will benefit this 40 years down the line. And this is true for blood pressure control, for glucose control, and lipid control. This is some interesting data that's coming out now. Again, we talked about the GLP-1, these therapies that help protect your heart, protect your kidneys, the injections, Wegovy, etc. And this is secondary analysis, but what we looked at was a systematic review of all the studies that have been done globally with SGLT2s and GLP-1s, these organ protective therapies. And what we found is they seem to benefit South Asians more than they benefit whites. Now, we're not sure why. And it may be because of the fat distribution we've talked about earlier on. And so Indians may get greater benefit of these drugs than the white populations do. But we need dedicated studies to look at this. All the guidelines say the same thing. 150 minutes of moderate to vigorous physical activity interventions for everyone. We need to now become really personalized because these are generic. And a lot of people say, well, I'm not going to do that. We talked about time. And again, my research group is looking at interventions, physical activity interventions, using objective measures. What we see is South Asians, although they're at high risk, for the same amount of exercise they do for a white compared to a white person, we get greater benefits. So simple things like standing 5 minutes every half an hour if you're on a sitting down job brings your insulin down, brings your glucose down by 25%. So simple interventions seem to benefit South Asians more than the white populations. So I think we should be talking about sitting, standing, walking for 5 minutes every half an hour, which leads to greater benefits for us than it does to the white populations. Making access to resources, again, we've done quite a lot of this, and I know that happens here quite a lot, but we need to do a lot more of this within the community. Self-management education, this is not telling the patient in a clinic, you need to do this, you need to do that. This is psychologically developed intervention. There's 6 hours of an intervention. And we've done randomized controlled trials that show that it leads to better outcomes for patients. And now we've converted them into different languages as well, different Asian languages. It takes longer, it takes double the amount of time, it takes 12 hours because there's an interpreter who is working and delivering that education. That I don't see much in India. In the UK, everyone has access to this free of charge. We easily write these drugs, the Ozempic drugs, they're £100+ we are per month. And we write that prescription and give it to the patient. These are simple, £80 it costs per year. We don't seem to promote these. They have great, great benefits. Same as gestational diabetes. We've done these studies in women with gestational diabetes. 40% were Asians. Again, simple educational interventions have massive effects. Increasing 500 steps you might per day. You might think 500 steps is nothing. 500 steps a day, if you increase your walking by 500 steps a day, you reduce your mortality risk by 10%. It's huge. So doing simple things well is really important. And finally, models of care. I know Nikhil's working on a model of care in India. You can't manage the high proportion of people, the numbers you're getting by specialists. In India, most patients still go to a specialist. In the UK, 90% of people with diabetes are managed in a primary care setting, in a GP surgery, because they've been upskilled to manage this. From those 90% of people in type 2 diabetes, doctors don't manage them in primary care. Our nurses manage them, and our pharmacists manage them. They've been upskilled to prescribe drugs. So majority of the management of people with type 2 diabetes in the UK occurs in a primary care setting by nurses and doctors. Our outcomes are not brilliant, but they're as good as the best in the world. Okay? And these are the most cost-effective models of care there are. And we've talked about multiple long-term conditions or multimorbidity. I think I can take that type 2 diabetes out, and we need to say multiple long-term conditions. 80% of people with diabetes will have lots of other conditions. So we should be managing these patients holistically in a primary care setting. And these are final couple of slides. This is something we've said in the UK, but it probably holds true in India as well. That the short-term goals are the ones in the dark: address preventative uptake, collect routine data, screen diabetes at a younger age, culture adaptive self-management, remote access to people, ensuring they don't get disparities, strengthen science. But the long term, if you really want to do something, it's not us, it's the government. Reduce educational inequality and invest in affordable housing and improve quality of employment. So in summary, there's growing evidence South Asians have more diabetes, their inequalities, their social inequalities will be driving this. We need increased investment in research as well. There's a lot more to do still. But if we're really going to tackle this well, a multi-sectorial approach is really required. And my final slide, we said this about 20 odd years ago, Professor Smani and I. And this epidemic of heart disease and diabetes in South Asians is a disease of migration for the UK. And that's occurred within one generation, wasn't there before. So there's no reason why we can't reverse this in a similar time frame. Thank you very much for listening.
Thank you, Professor Kamlesh Khunti, for that wonderful keynote lecture on diabetes in Southeast Asians, South Asians in particular, and your focus has been on South Asians living in the UK. But as you know, the same problem is there in South Asians everywhere, whether they live in UK or in their home countries. One of the first studies, in fact, in 1986, around 86 or so, which we did with Dr. Harry Keen's group and the Ealing group in South Hall, showed that, you know, while the South Asians in Europe had fourfold rise in diabetes compared to the Europeans there, it was similar to a peer group or a similar group in Delhi, Daryaganj study, and that probably was one of the first to recognize that, you know, it's the South Asians themselves who are predisposed. It's not just the effect of migration. That's one. And as you rightly pointed out, South Asians have an earlier onset, maybe a decade earlier. They are less active. the less access to medical care and medications. All these are multiple problems which make South Asians particularly vulnerable in terms of diabetes complications and cardiometabolic risk. And I think that was very well brought out by you. One interesting thing that I observed from your talk, and which you, I think, rightly highlighted, was the preferential benefits of GLP-1 analogs, for example, in South Asians. And we've also, in clinical practice, many of our colleagues would agree, in terms of weight loss and in terms of glycemic control as well. We somehow seem to be doing a little better, and some of the patients do really well. I mean, much more than what is even given in literature in terms of weight loss, for example. So I think that's another point which for us is a learning thing, and we should pursue, and more research, and that probably will be needed. With those comments, if my chairman has something to say.
Very nice lecture, no doubt. Multiple times listened to you. It has been always quite good. After listening your lecture, what I could really transpire that no doubt Southeast Asia diabetes is different than that diabetes in the Europe for multiple factors. Like we had the early onset, as sir has said, we had the faster progress towards the complications. We start treatment late because of what we lost the legacy effects. We don't treat the GDM also up to the, our incidence of the GDM is also very high. But despite all these things, we respond faster to the medication. May it be GLP-1 analog, may it be DPP-4 inhibitors, or may it be SGLT2 inhibitors. You can see that our response is always better than the Western countries. But still we follow the same treatment protocol, what is being followed in those places where it is different from us. What's yours?
You're absolutely right. And first of all, you get better response with these therapies because the HbA1c is higher, as I showed you in Asians. And any drug you take, if your HbA1c is high, the reduction you'll get is a proportion of where the HbA1c is. So if you've got a high HbA1c, you'll get a greater reduction. I think that's one of the reasons that you do see it. But I think there is certainly, with certain therapies, you do get better benefits. In terms of protocols, they're all being done on white populations. And I'll give you an example, hypoglycemia. Hypoglycemia is defined as when the blood sugar goes below 3.9. And we don't see as much hypoglycemia in Asians. We've done a global study looking at hypoglycemia in about 12 countries, including India. And overall, hypoglycemia was lower in Indians. And the reason is this 3.9 has come from very intensive, what were the clamp studies, where they bring the glucose down under experimental conditions and then see when patients start getting symptoms. They were all white patients. So all the studies have been done in white Europeans, white Americans, and we are transferring that recommendation to the Indians. And that's why I say we do need separate studies, and we can do them in the UK, but they won't fund that for large numbers. You've got the numbers here to do some of these very transformational studies that may change guidelines.
I don't know how many your ethnic minorities could present there with the malnutrition, which is the additional risk factor in India.
Yeah, we don't have malnutrition.
So you don't have
we have overnutrition.
It's really difficult to observe from UK to Indian setup of the malnutrition.
Yeah.
And of course, you have very rightly observed our administrative difficulties, poor access to the treatment, and people, those who are even knowing their diabetes, they are not treating. What we could really observe in our rural outreach program of the RSSDI, which we are running nowadays, and we are seeing that people are comfortably walking with their 250 and 350 blood sugar level, and without taking any treatment, and they are saying that we don't have any problem, and they are not really bothering of the legacy effect complications, and they are getting diabetes in the 20s and 30s.
That's the attitude, as I showed you. We've got the same attitudes in the UK. This is we have second generation, third generation Indian. They still have that same attitude. That generational information has carried on.
Would like to have a comment from Dr. Madhu also on this, that we are having so much difference from the diabetes, but still we follow the same treatment.
As I think Dr. Kamlesh has already said, it's more an attitude and a mindset problem than anything else, and that needs to be addressed separately through counseling and other measures. That is part of the problem. Just the last comment before we conclude the session maybe, is the fact the response to drugs, and not only drugs, even physical activity among South Asians, I think that's partly, as you said, partly because of the fact that the fat distribution is different, and that maybe in the liver and other places and in visceral fat, that tends to come down very fast, and the benefits in terms of cardiometabolic risk probably would accrue much faster. And in fact, we observed the same thing, and we hypothesize that probably diabetic reversals programs would work much better in South Asians, and that needs to be also checked.
Yeah.
I think we will have the questions for the panel discussion, and with this again thanking Professor Khunti for that wonderful lecture, we conclude this session. Thank you, sir.